Dr. Nagwa Hamdi, consultant of neonatology at Al Jalaa Teaching Hospital, following the general organization of teaching hospitals and institutes. Today, we are going to demonstrate umbilical catheterization, both venous and arterial umbilical catheterization. The contraindications for umbilical catheterization, both venous and arterial, is omphalocele, gastroschisis, omphalitis, infection, necrotizing enterocolitis, and peritonitis. A consent should be obtained from the parents as per the guidelines of the facility. Under complete aseptic condition, the healthcare provider will wear a head cap, a face mask, gloves, and sterile gown. The procedure is performed under complete aseptic condition. The baby is placed in the supine position with straining of both the upper and lower limb. We'll sterilize the abdominal skin around the umbilical stump and the umbilical stump. We'll apply sterile drops around the area. Predetermine the length of the umbilical catheter, both artery and vein, the length of insertion, and connect the umbilical and venous catheter both to three-way stopcock and heparinized saline in a 5 cc syringe. Apply an umbilical tape around the base of the umbilicus. And with the knife, cut the umbilical cord 2 centimeters from the abdominal wall. Identify the both vessels, artery and vein, at the cut umbilical stump. Usually the vein is thin-walled and widely opened, located at approximately 12 o'clock position. The 2 umbilical arteries are thick-walled, pinpointed, protruding from the umbilical stump. If sometimes there is a clot at the tip of the umbilical vein. If so, remove this clot, approach the opening of the umbilical vein and insert the catheter to a distance of 2 centimeters and withdraw blood. If blood is withdrawing in the catheter, then push the catheter inside for the predetermined distance of the catheter and push the heparinized saline through the catheter. The proper level of the catheter should be above the right side of the diaphragm or the right copula of the diaphragm. The length, the predetermined length of the catheter is determined from graphs of the shoulder umbilical length or the weight of the baby. Stitch the umbilical vein catheter to the umbilical stump, taking care not to puncture the wall of the vessel. Take a perthes suture and roll the thread around the umbilical venous catheter. make sure to dispose any sharp objects in the safety box. And then we are going to catheterize the umbilical artery. Widen the opening of the umbilical artery. We use the curved iris forceps. With the tip of the forceps, apply slight and steady pressure at the tip of the umbilical artery and open the tip slightly, and then close and apply. Go a little bit deeper and apply pressure again and open the tip of the umbilical of the forceps again, and so on until a distance of around 1 centimeter. You may encounter resistance during the entrance. We need to wait for a few seconds until the spasm in the artery fades, and then try again. Removing the curved iris forceps, with the umbilical insert the umbilical catheter inside the umbilical arterial catheter inside the opening of the umbilical artery. Slowly with steady pressure. Don't push, because this may puncture the wall of the umbilical artery and it will create a false tract. With steady pressure, gently and slowly insert the umbilical arterial catheter to a distance of around 5 centimeters, and then try to withdraw blood. If blood is withdrawing, that means that we are in the right space. So continue insertion of the umbilical arterial catheter to the predetermined length. Now we have to connect the catheter to heparinized saline in a concentration of 0.5 units per 1 ml with a continuous infusion of 0.5 to 1 ml per hour to keep the umbilical arterial catheter patent and prevent the formation of blood clots. Confirm the position of both umbilical arterial and umbilical venous catheter radiologically. Stitch the umbilical arterial catheter in place by a purse string suture and rotating the thread around the umbilical artery to fix it in place. For sampling of blood from the umbilical artery, we will aspirate 1 cc of blood. For fixation of both catheters using the umbilical bridge, remove the umbilical tape. This way. Today we are going to demonstrate intraosseous access in neonates. Intraosseous access is a life-saving procedure which is carried out in neonates in emergency conditions where vascular access, whether peripheral or central, is not feasible or difficult. It is used for sampling of all types of blood investigations, and it is used also for the administration of fluids, glucose, medications, and blood. It's relatively more safer and quicker and requires less skill than other intravascular accesses. The contraindications to intraosseous access: the equipments needed for this procedure is a sterile glove. We need alcohol swabs or any antiseptic solution. We need the insertion needle of different sizes according to the weight of the baby. We need, if we are going to do the battery operated drill technique, we need the drill using the EZ10 battery operated drill, a roll over towel, 5 cc syringe, 3-way connection, a connector tubing. We need a tag for registering the date and time of administration, and we need an adhesive plaster. A consent will be needed if the guidelines of the facility indicates or that. The procedure needs to be explained to the parents. To locate the site of insertion in the proximal tibia, we will first locate the patella, and then the lower pole of the patella. We will look going distally or moving distally. We will palpate the first bony prominence, which is the tibial tuberosity, around 1 to 2 centimeters below the tibial tuberosity and to the medial side. This is the site of insertion. Why this site is preferred? Because it is the flat area of the tibial bone where the skin and subcutaneous tissue is not abundant or is thin. We have to put a roll over towel under the knee of the baby. This will give better support to the area of insertion. The procedure is performed under an antiseptic technique, wearing sterile gloves after proper hand washing with an alcohol swab. Rub the area of insertion in a circular manner from inside out. And then after choosing the proper size needle, we have 2 techniques or 2 ways to perform intraosseous insertion. We have the manual way and the battery operated drill way. The manual way, choosing the proper size of the needle. The needles are have sharp beveled ends with trocar and cannula. Putting the base of the needle in the palm of the hand and supporting it properly by the index and thumb. Approach the site of insertion in a perpendicular manner and pierce the skin and subcutaneous tissue. After piercing the skin and the subcutaneous tissue by applying pressure to the site of insertion, we will reach a point of resistance. This is the periosteal bone. And then with regular sustained pressure and screwing movement of the needle to puncture the periosteum. The periosteum is punctured when we feel a pop-off or a give-way resistance. After piercing the skin and subcutaneous tissue, in a screw-like movement with guided pressure, guided steady pressure, pierce the periosteal bone until a pop-off or a give-way sensation is felt. Then the needle is in the marrow space. Remove the cover of the needle and remove the inner stylet. If the needle has a flanging screw, then rotate the screw so that the base surfaces or the base surface levels with the skin of the baby. This gives better support to the needle. How to know that the needle is in place? The needle stands alone on the bone, it does not move, and we can aspirate blood from the marrow space. This sample will be sent to the lab for investigations, making sure to label the sample as a bone marrow sample in the lab form. Connecting the tubing to the cannula and through a three-way I will inject 5 cc of saline into the marrow space, followed by another 5 cc of local anesthetic, because the fluid going into the marrow space will go under pressure and the medullary cavity in the medullary cavity, and this will cause some pain. Then I will connect my fluid through the three-way and give fluids. This fluid should be run under pressure because intraosseous marrow space, the fluid does not go by gravity. It has to go under pressure. So we can either withdraw boluses of 10 ml saline and inject it through the cannula, or we can apply and repeat it several times, or apply pressure to the fluid pack through a manometer adjusted to 300 millimeters mercury. After that, the fluid is running. We fix the cannula in place by plaster. Like this. The cannula, the intraosseous cannula, can be inserted for at most or for 24 hours most until another vascular access is obtained either through peripheral or central lines. To remove the intraosseous cannula, we stop the IV fluids, disconnect the tubing, remove the adhesive tape, connect a syringe to the cannula, and by rotating the cannula with the syringe, remove the cannula from the bone. Removing the cap of the needle, we will approach the site of insertion in a perpendicular direction to the bone, piercing the skin and the subcutaneous tissue until resistance is felt due to the bony periosteum, and then press the button on the drill and the needle is inserted. Rotate the drill handle in an anti-clockwise manner. Remove the stylet of the needle and we know that the needle is standing in place. We know that there is insertion of the needle into the marrow cavity. By that, the needle is standing in place. Blood is withdrawn from the needle. The sample is sent to the lab. The complications of intraosseous insertion may be inappropriate insertion of the needle so that it's not in the marrow space. This will lead to extravasation of the fluid in the surrounding tissue. This will be noticed during the injection of the fluid into the cannula. We will have to observe the surrounding tissue and the calf area of the skin and palpate it for any firmness. If this was not noticed and extravasation is already going on, so this will lead to the so-called compartment syndrome. Then we apply a band around the wrist of the baby and label on it the date and time of insertion. Today we will demonstrate the needle aspiration technique for pneumothorax. Pneumothorax is the presence of air in the pleural cavity. It is a serious condition in the newborn which, if extensive, may cause severe progressive respiratory distress with hemodynamic instability which compromise the oxygen saturation in the blood. It's treated in two ways, either to do needle aspiration or to proceed after needle aspiration to chest tube insertion. The indications of needle aspiration is an extensive pneumothorax. If we do transillumination, we will find that there is a positive test on the affected side. The equipment needed for needle aspiration is we need a surgical glove, we need to wear a mask, we need a hygienic hand wash, and we need a butterfly needle, we need a 3-way connection and a 10 cc syringe. Now we will start to perform the procedure. First of all, I have to wear a face mask, perform a hygienic hand wash, and then wear my gloves. I will sterilize the area of insertion by a simple alcohol swab, and then I will identify the site of insertion. The site of insertion is the mid-clavicular line. Here's the clavicle, and then I will go first intercostal space, second intercostal space in the mid-clavicular line. This is my site of insertion. If I have a marker, it's better to mark the site of insertion. Then, if it is possible, I can give a local anesthetic to the baby if time permits. If not, and the condition is an emergency, so I will perform the procedure directly. I will connect the 3-way connector to the butterfly needle, and the other side or the other port of the 3-way connection, I will attach to it the 10 ml syringe. Now my connection is ready. I will align my connection so that the syringe and the butterfly needle are on one line, and the opening to the outside atmosphere is closed. At the site of insertion, I will approach the skin and I will insert the needle perpendicular to the skin and advance downwards until I feel a pop-off or a give-way feeling. Support the needle at the site of insertion and I will start to suck air or withdraw air inside the 10 cc syringe until it is full. Once the syringe is full, I will change the direction of the three-way so that I close the connection to the butterfly and align the 10 cc syringe with the port of the outer atmosphere. I will push the air out and then again I will realign or redirect the three-way so that the butterfly is in one direction with the 10 cc syringe, and I will repeat the process of withdrawal of air again until the syringe is full. I will redirect the needle again and push the air outside, and so on until I find resistance to the withdrawal of air through the butterfly needle. I will stop, repeat my trans-illumination again to see that the air has been emptied from the pleural space, and the trans-illumination test now is negative. I will hear the air entry on the affected side. Better air entry should be there now. And I will look at the oxygen saturation and the vital signs of the baby. If it is improving, then I have emptied the air from the pleural space. I remove the butterfly needle and I will apply petroleum soaked gauze over the site of insertion, or I can use a gauze soaked with Vaseline. We'll be demonstrating the chest tube insertion procedure. Most of the time, the needle aspiration will be followed by a chest tube insertion. There are certain precautions to be taken before performing this procedure in babies with coagulation disorders, bleeding disorders, or severe thrombocytopenia. We should treat these conditions either before or during the performance of the procedure. I need an informed consent from the parents before performing the procedure. If the parents are not around or I'm not able to reach them, so a consent from the covering consultant of the unit is enough. And then I will inform the parents after that about the procedure and will explain to them what happened in the procedure. Procedure should be carried out under complete aseptic condition. I will position the baby and I will identify the site of insertion of the chest tube. I will position the baby in the supine position with the hand on the affected side placed superiorly next to the head of the baby and supported there, either by a strap or the assisting nurse. I will locate the site of insertion of the chest tube in the 4th or 5th intercostal space in the mid-axillary line. So I will count the 1st, 2nd, 3rd, and 4th intercostal space in the mid-axillary line. Again, I will put my chest tube on the upper border of the 5th rib to avoid putting it on the lower border of the fourth rib where there is a bundle of blood vessels and nerves. Better to mark the site of insertion. I will sterilize the area with an appropriate antiseptic solution and leave to dry for a few seconds. And then I will put my sterile dressings. I will then give a local anesthetic, lignocaine 1%, penetrating the skin, and then subcutaneous tissue and the intercostal muscles surrounding area. I will make a longitudinal incision along the fourth rib, 0.5 centimeters in length in the skin. And then with the curved forceps, I will enter this incision through the skin, and by an opening and closing movement of the curved forceps, I will push into the subcutaneous tissue and intercostal muscles until I reach the resistance, and this is the parietal pleura. I will close my curved forceps and push forward through the pleura, guided with my finger until it gives way. And then I will withdraw the curved forceps and get the chest tube and hold the tip of the chest tube with the curved forceps so that the tip is slightly protruding beyond the tip of the forceps. The distal end of the chest tube I will close with a clamp and enter, guided by the finger, the incision I had made before until the chest tube is inside the pleural cavity. I will release my curved forceps and withdraw it, and I will support the chest tube in place. Then I will connect the chest tube to the two-way connector of the water-sealed bottle and open the clamp to watch for bubbling of air. Now I will fix the chest tube in place. I will stitch the skin, one side of the incision. I will take one stitch. I will rotate the thread, and then I fixed the chest tube in place now. I will cover it with the petroleum soaked gauze. Fix the area with Tagadur. After fixation of the chest tube and the air is bubbling in the underwater seal, I will take an X-ray, I will obtain an X-ray for this baby to make sure that the pneumothorax is draining and the lung has inflated. I will look at the cardiorespiratory monitor. The vital signs of the baby should be improving and the saturation should be improving also. If after X-ray I found that there is no proper drainage for the pneumothorax, I will apply pressure to the underwater seal. The complications of this procedure.
This video to demonstrate lumbar puncture in neonates. First step is sterilization using betadine in circular direction from inside outwards. Then we will use towels for the baby. The assistant will catch the baby in flexion attitude for the knees and for the neck. Knee. Then we palpate the iliac crest on both sides. An imaginary line between the two iliac crests is opposite to the level of L4. In neonates, we can use a needle of a syringe in the midline and go perpendicular to the vertebral column. I will introduce the needle perpendicular at the level of L4 till I reach the flow of CSF and collect the sample in collecting tubes. I will remove the needle with pressure for about 1 minute.
لازم اتاكد الاول ان انا عندي فول بلادر. اتاكد ان انا فول بلادر يا اما استخدم الترا ساوند او يكون عندي ترانس اليمينيشن اوف جاست ان انا اعمل بركشن. هعمل ازاي؟ هعمل سوبرا بيوبيك اريا. كل حاجه استرايل، بعمل بركشن، اتاكد ان انا فول بلادر الاول. اتاكدت ان هي فول بلادر عشان ما يحصلش ريفلكس يورينيشن، بعمل كومبريشن على الجينيتاليا والانس وابدا ادخل بسرنجه 3 سم. بدخل ازاي او فين السايت اللي انا بدخل فيه؟ بدخل فوق السيمسس بيوبس من 1 ل 2 سنتيمتر. بمسك السرنجه بيربنديكولار بدخلها، بتدخل تقريبا من 1 ل 2 سم واعمل اسبريشن لليورين. اول ما الاقي فيه يورين ستريم معايا في السرنجه باخد اليورين اللي انا باخد من 1 ل 2 سنتيمتر اكوردنج ان انا هعمل كلشر او هعمل جاست يورين اناليسيز. ما بحركش السرنجه وانا انسايد، لا اوبليك ولا اي دايركشن عشان ما اعملش انجري لاي باول. فبدخل بيربنديكولار، حتى ايفن لو ما فيش يورين ستريم ما بتحركش بالسرنجه خالص، بطلع لو ما فيش. لو معايا يورين سامبل باخد السامبل اللي انا هاخدها من 1 او 2 سم اكوردنج اللي انا هعمله، وجاست بعمل كومبريشن مكان ما اخدت السامبل.